diseases, including HIV and hepatitis and all those kinds of things. We're looking for safer ways to put these patients in fixation. So the variations of this type of arch bar have been developed over the past 10 or 15 years, and these are actually screwed to place directly into the bone. I'm going to put the screws between tooth roots, not into tooth roots. So you'll see some of these are the screws are not directly beneath the hook where they were originally set, but they've been bent to one side or the other, and we do that so that we avoid hitting tooth roots. These are a lot faster to put on than wires around the teeth as well. We can put a set of these on in about 10 or 15 minutes. It takes about 40 minutes to wire arch bars to individual teeth. So in this case, we're not using rubber bands to hold the teeth together. We're using wire. Either is acceptable. Rubber bands obviously are easier to get off in the event of a patient having nausea or vomiting. Wires would have to be cut. All these patients that are wired together with these things actually are given wire cutters to bring with them everywhere they go until things heal. It takes about 6 weeks for the bone to heal completely, a little bit faster in younger people, sometimes a little bit slower in older people. But this is a fairly typical way to do a closed reduction and hold the teeth together in normal anatomic position so that you have a good occlusion as the patient heals. Splints, I already mentioned, we use in kids commonly. This is actually one I did in the clinic at UB here a few years back. So what we do is sedate the patient, take an alginate impression, cut the cast if we need to do that to realign the teeth, then fabricate a splint out of orthodontic resin like you would do for any orthodontic appliance. You see these holes that are drilled in it. Those are then wired around the teeth to hold the jaw stable while the patient heals. And in this case, because it's a kid, they don't tolerate maxillomandibular fixation very well, so they can open and close while they're healing. And they heal quick. So it may only take 2 or 3 weeks for these kids to actually get a pretty good bony bridge. Dentures can be used to repair these types of fractures as well. Both of the fractures you see here would be considered comminuted fractures. On the left side of the screen, you see that there's multiple segments of the mandible, and those little black areas, one is an endotracheal tube, goes into the trachea, and the other is a nasogastric tube that's draining secretions from the stomach. And you see there's no other air around that. There's a lot of swelling associated with this type of fracture. Right. So the endotracheal tube is what's maintaining the airway in this patient. On the right slide, you see that's the maxilla. The maxillary sinuses are not filled with air except for a few dots of air on the patient's right side and the left side of the image. But you see there's multiple segments of bone, and the maxilla is actually split down the middle as well. There's a fracture line. And on the patient's left, right side of the image, you can see the condylar head and neck is separated from the ramus of the mandible. So a lot going on in this patient. And when you have fractures like this, the patient doesn't have teeth. When you have multiple segments like this, it's pretty hard to get everything back together. So in many cases, we can do this if they have dentures by splinting their dentures in place. As you see here, and see again, these arch bars are wired to place. We usually take the teeth off the anterior part of the denture so the patient can get in some food easier. And this works pretty well. And you leave these patients together till the bones heal for about 6 weeks. They'll need new dentures afterwards. Another common way we deal with mandible fractures nowadays is by open reduction and internal fixation. So this is a plain film, a posterior-anterior mandible image that shows a fracture at each body and angle region. Okay, so there's a fracture on each side. And when we have a situation like this, you can see that's a fairly large incision. So remember, incisions heal across the incision, not along its length. So the longer it is, doesn't make it more difficult to heal. It still takes the same amount of time. Well, you can see the access we have to the fractures and the instruments that we can use to reapproximate those fractures so that the patient actually has normal anatomic appearance. And if they have teeth, we would use arch bars as well to put the teeth where they belong first, then the bones second. If the bones aren't in the exact position, not a big deal. They will remodel. If the teeth are not in the exact position, the patient will have difficulty chewing forever. As you can see, these are fairly heavy metal plates. They have screws on either side of the fracture line. Got to have at least 2, preferably 3 screws on either side of the fracture to hold it pretty rigid. When we do this kind of thing, patients can open and close while they're healing, so they can get in at least liquids almost right away. These are very good methods to repair these fractures. There's minimal pain after the first few days, and the patients get back to function much more rapidly. Now, we had arch bars on to establish occlusion if they have teeth, but they don't have to keep their teeth together while these heal. These are fairly heavy plates, and they can function on these almost immediately. One thing that's important to note is the plates need to be below the inferior alveolar nerve. We don't want to put screws through the nerve where the patient will have a numb lip forever. And different images of the same thing. This guy doesn't look so bad when he's done, as you can see. And he went on to do very well. Postoperative imaging. Those screws go all the way through the bone, both cortices, and usually the tip pokes just through the lingual cortex. Now, edentulous fractures are a whole other problem. The patients that have these fractures, they have no teeth to help us, so they typically have to be opened. One of the concerns is that if you don't use big enough hardware, you get a situation like this. This was a day or 2 after this patient had this done by another surgeon, and you can see that the plate fractured. Now, these are small plates, and they would not withstand the muscle pull or any swallowing or taking food by mouth for this patient. So even in a period of only a couple of days, plates broke. Well, you can't leave this. This is something called, sometimes referred to as a bucket handle fracture. So it's bilateral body fractures. And the concern with this is that the tongue will, when you get a fracture like this, the tongue tends to drop posteriorly and impede airway. So you have patients that have difficulty breathing because their tongue is blocking their airway. So these do need to be repaired. And in this case, the patient was taken back. This is one that I did probably 10 years ago here. You see a much heavier plate in this case. And because the patient has no teeth, you're much less concerned about trying to establish perfect anatomy. But this patient will function on this plate until the bones heal. But the plate is heavy enough that there won't be mobility across the fracture lines, and they will heal.